We'll just give everyone a minute or so to get logged on. While we're waiting for everyone, I just want to remind everyone that this is eligible for 0.1 ASHA CEUs, and we ask that you stay for the entire length of the presentation and fill out the survey at the end. I will put the survey link in the chat. The survey will be open for 1 week, so until April 24th. The recording will also be posted on the Timms University website, which I'll also post a link for that. And we'll also have the PDF of the references for you all as well. And so with that, we're a minute after, so we'll go ahead and get started. So I'll just quickly introduce myself. My name's Shannon Marks. I'm one of the speech pathologists and training and demonstration managers here at Timms, and I'm super happy to have Brooke present on a multimodal approach to dysphagia in head and neck cancer. So without further ado, I'll pass it off to Brooke.
Thanks, Shannon. I'm going to go ahead and share my screen. Wonderful. And I do have a lot of slides, so I'll start with that. So if you have questions, feel free to pop them in the chat as we go. And Shannon is here with us in the background and can help answer questions. But if we run up to the 60 minutes and you need to jump off for whatever reason, you will still be able to get ASHA CEUs for this presentation. But I just wanted to preface that we may go a little bit over the 60-minute mark potentially. So with that, we'll go ahead and dive into it. Like Shannon said, this evening we are going to be discussing a multimodal approach to dysphagia in head and neck cancer. My name is Brooke McGivern. I am a full-time member of the Timms medical team. I'm in the role of Director of Marketing and Communications here at Timms, and I also practice clinically in the acute care, inpatient, and outpatient settings, and I teach a dysphagia course at Maryville University. And I've had a passion for head and neck cancer since graduate school. Way back in the day, I road tripped down to Houston to MD Anderson with some friends in grad school and took a laryngectomy course that was taught by Brad Smith. And that really sparked my interest and passion for working with this patient population. And ever since then, I have been involved in working with people with head and neck cancer. So that's a little bit about me. Now kind of diving into what we are going to be discussing this evening. At the conclusion of this presentation, I hope that you are able to describe acute and chronic ramifications secondary to head and neck cancer related specifically to swallow function, that we are all able to summarize the benefits of intervention for dysphagia during treatment for head and neck cancer, that we can compare and contrast the benefits and differences of FEES and MBS specifically for people with head and neck cancer, and that you are equipped with a variety of modalities that may be beneficial in supporting improved swallowing outcomes for people with head and neck cancer. And here is our time-ordered agenda. All right, so diving right into our content for this evening. Sorry, I'm going to move this Zoom thing real quick here. Okay. So I wanted to start by just talking about risk factors for head and neck cancer. So if you work with this patient population, this may not be news to you, but just wanted to start here at the ground level. Risk factors for head and neck cancer include the use of tobacco products, alcohol consumption, environmental exposures, the human papillomavirus, which is often referred to as HPV, and consumption of some processed foods. As we see in the literature, the use of alcohol and tobacco together create a synergistic effect, and the literature demonstrates that those who use both alcohol and tobacco have an increased risk for the development of head and neck cancer by 40-fold. In recent years, we have seen trends change a little bit in terms of the caseloads that we are seeing for people with head and neck cancer. So we are probably all familiar with the term human papillomavirus or HPV. HPV is extremely common, and it often impacts the oropharynx, the hypopharynx, the larynx, and the oral cavity. Typically, there's an increased survival rate for people who develop head and neck cancer with HPV compared to non-HPV related head and neck cancer, and often there's a diagnosis at younger ages. So this is what I meant when I said that we're seeing trends change over the past several years in terms of our caseload. Often we are now seeing patients that are younger in age when they're diagnosed. They have an increased rate of survival, which is great. But the other flip side to think about is when these patients are younger, they often have a longer lifespan to deal with the chronic ramifications of cancer and the ramifications caused by the subsequent treatment. So in my own clinical practice, I've seen patients in their 30s, 40s, and 50s. And when we think about lifespan, someone in their 30s hopefully has 60 more years to live or more. So my mind goes to for all patients, how do we move out of a survivorship mentality and think more about how do we help these patients not only survive but actually thrive and get back to living life on their terms. So as I mentioned, the human papillomavirus is extremely common. It's the most common STI. And I do want to provide a little bit of information about HPV because in my own clinical practice, I have been faced with having these conversations with the patient and with their significant other as they are hearing terms like, oh, my husband was diagnosed and they said that he's P16 positive. What does that mean? I Googled it and here's what I found. So, these concerns can come up and they may just land in your office. So I think being informed about just some basic information about HPV can help patients navigate through those conversations. So as I mentioned, it is one of the most commonly sexually transmitted infections, and it can be obtained from having any form of sexual activity one time. In addition to that, it may lay dormant in the system for years. And I think that those two points are extremely important for patients and their spouses to be aware of. Several years ago, I was part of a development of a support group for people with head and neck cancer, and some of the sessions we had spouses come, and then we had another separate session just for the spouses, and listening to the things that the spouses and the caregivers and the families go through was just very eye-opening, but this is one of the topics that often came up. So as I mentioned, strain 16 and 18 are the most common for HPV. So again, we're probably all familiar with the treatment for head and neck cancer, but just to review, treatment for head and neck cancer may include surgery, radiation, and chemotherapy, as well as more recently, immunotherapy. Some patients may have only surgery, they may have surgery and radiation and chemo, or they may just have radiation or just chemo. It really depends on the patient. But in my experience, most patients have surgery, radiation, and chemo, or at least radiation and chemo together. So before we really dive into our content for this evening, I want to bring up the topic of decisional regret. When we look at the literature, we see that the primary reason that people with head and neck cancer regret treatment completion is related to swallow function. And that is a heavy burden to bear and to think about as speech pathologists because we kind of navigate the ship in terms of swallow function. So I think it's important that we know this and that we are prepared with this information because it can help us really be proactive in terms of not only intervention, but also counseling and education. This fact alone really helps provide the premises for why we should be involved in those initial discussions with the patients to help them understand what could potentially happen with their swallow function, how we can be there to provide support, and so that they can truly make an informed decision. Additionally, when we look at the literature, we see that patients with head and neck cancer are 3 times more likely to commit suicide compared to the general US population. So again, this is a really serious and heavy topic, but again, lends to the importance of our role as speech pathologists in being advocates and being support systems for our patients and really promoting interdisciplinary care and support for these patients. Again, as we are thinking about just our scope of practice and referrals for evaluations and treatment modalities, we should also consider the financial ramifications that these patients incur due to head and neck cancer. So just a couple of general facts to begin with. The average cost of PEG tube placements, according to MD Save, and this is from this year, is anywhere from $6,758 all the way to, from $4,930 all the way to $6,758. In terms of the annual cost of PEG tube feedings, research from Callahan in 2001 and Wang in 2014 indicated that it's a little over $30,000 a year. And of course, those articles were published several years ago, so I'm sure it has increased in 2025. Additionally, we are all well aware that hospital readmission due to the consequences of dysphagia can have financial ramifications, which again can total around that $30,000 mark. And of course, we are all well aware that dysphagia is associated with longer hospital stays, higher inpatient costs, and increased likelihood of discharge to post-acute care facilities, as well as increased mortality. And dysphagia during hospital admission may increase the cost by 60%, and that's a little bit more recent in 2020. And then, of course, if patients are on thickened liquids, we know that they can have financial ramifications up to $2,400 or more per year. And in people specifically with head and neck cancer, they often have esophageal dilations routinely, which again, per MD Save, can range anywhere from $1,456 to $2,943. So just in listing off those couple of bullet points, you can see how quickly people with head and neck cancer can develop financial burden just solely related to their dysphagia, not even including any of the other acute or chronic issues that we will discuss this evening. In 2022, Massa and colleagues reported that they found that costs associated with head and neck cancer lasted for at least 5 years after diagnosis, and that the median healthcare costs averaged $372 a month, but could progress all the way up to $2,714 a month. So again, if you're thinking about this, let's go the high end. If you're paying $2,000 a month every month for 5 years, that's a mortgage payment that they're paying in addition to all of their other normal bills. So it's important that we're aware of these financial ramifications, because we can help play a role in decreasing burden of appointment fatigue, as well as potentially these financial ramifications that the patients are enduring. So with that, let's go ahead and dive into our acute and chronic ramifications. So there's a lot more than this, but just to kind of dive into some of the common ramifications that you may come across in your practice. Odynophagia, which is painful swallowing; xerostomia, which is dry mouth; dysgeusia, which is changes or alterations in taste. Salivary changes are extremely common, so many patients develop alterations in their saliva. I just had a patient last week who had extremely thick, ropey, white saliva. Fibrosis, so fibrosis can be caused by radiation fibrosis syndrome or end-stage lymphedema, which is our next bullet. Lymphedema is extremely common for this patient population, and it's important to note that lymphedema can be internal and external. Dysphagia, of course, is extremely common. Additionally, people may develop issues with breathing, changes in their communication, osteoradionecrosis, laryngeal necrosis, trismus, which is reduced jaw range of motion, fatigue, which is typically systemic, and neuropathy. And of course, this just is the tip of the iceberg. Patients often develop a plethora of symptoms, but these are often symptoms that I have seen in my own clinical practice. And as we go through this list, you can probably point out many of these that could potentially lead to swallow dysfunction or difficulty with oral intake. Okay, so after looking at that list, I just pulled out a couple of acute and chronic issues that occur for people with head and neck cancer, and did a little dive on the prevalence of each of these. So to start this list, in 2020, Raja et al. Found prevalence of trismus to be 38%. Multiple studies demonstrate the high prevalence of xerostomia at 80%. Oral mucositis was found to be 94%, fibrosis 50%, and lymphedema 96%. So again, as you're thinking about our role as speech-language pathologists, it's critical that we're looking at the whole patient and understanding how each of these pieces of the puzzle can lend to difficulty with oral intake as well as swallow dysfunction. And you can see how highly prevalent most of these things are for this patient population. So as you can probably guess, this presentation could be much longer than 1 hour, so I don't have time to dive into each of those acute and chronic ramifications this evening, but I did want to do a little dive into the lymphatic system, because I don't know about you all, but I did not get a lot of education or information on the lymphatic system in graduate school, although I did get education on it at the conference at MD Anderson. However, I wanted to provide just some foundational information about the lymphatic system for those of us who are just starting to dip our toes in this area. So the lymphatic system is an important aspect of the circulatory system, and it is crucial for our immune function and in the drainage of excess extracellular fluid. The components of the lymphatic system include the lymph itself, lymphatic vessels and plexuses, our lymph nodes, lymphatic cells, and various lymph node organs. What I think is so fascinating, because the body is so complex, is the fact that there are more than 300 lymph nodes in the head and neck. So 300 just in this area, which is obviously our prime area of expertise as speech pathologists. Unfortunately, risk factors for lymphedema include radiation, surgery, and chemo. And if you work with this patient population or are just learning for the first time, like we said in the original couple of slides, these patients often undergo one or multiple of these treatment options, radiation, surgery, and chemo, which we know are risk factors for the development of lymphedema. So I'm going to provide kind of just a metaphor about the lymphatic system as I explain it to the patients that I work with. I like to think of the lymphatic system as a highway. So the vessels are the road and the lymph nodes are the stoplights. So if our lymph system is healthy, the traffic is flowing, everything's going good, we're not, in dead stop traffic on the way to work. Now, if damage happens to the system, we get a traffic jam. So this photo on the left, I'm sure everyone can attest to the pain of rush hour traffic. And when this occurs, we get, in the lymphatic world, what's called dermal backflow. So the lymphatic fluid stops flowing appropriately and it becomes stagnant. So in the photo on the right-hand side of the screen, you can see some images from a study conducted by Gutierrez et al. In 2019, where they used green dye to assess the flow of the lymphatic fluid and determine the effectiveness of advanced pneumatic compression in mobilizing that fluid. So we can see with green dye that the fluid does become stagnant, and we can actually reroute this fluid not only with advanced pneumatic compression, but with manual lymphatic drainage and other techniques, which we will talk about this evening. But my purpose in showing you this is to show you what happens to the lymphatic system when there is damage. The fluid becomes stagnant, and if it's not addressed over time, it becomes more and more edematous and eventually can lead to fibrosis. So we obviously, as speech pathologists, don't have access to green dye, but we do have access to FEES and MBS. So I wanted to show you some photos of internal lymphedema and what lymphatic dysfunction internally looks like. As I mentioned, that study conducted by Jeans et al. In 2023 found that 96% of people with head and neck cancer develop head and neck lymphedema. And that study is amazing. So if you haven't read it, I highly recommend checking it out. But on this slide, I just wanted to demonstrate visually some of the changes in patients that I have worked with. So on the left-hand side is a picture of my airway for reference, so that if you're not familiar with FEES, you can compare what my airway, which does not have lymphedema, looks like compared to people on the right-hand side who have severe internal lymphedema. So obviously, these are not videos, these are still photos, but even just on looking at these photos, you can start to hypothesize how these patients would have such severe issues swallowing, breathing, speaking, etc. It's just eye-opening, I think, to do FEES with these patients, because you get a really clear picture of the level of edema internally, and how that is impacting not only swallow function, but also airway integrity. So what does external lymphedema look like? External lymphedema can have a variety of presentations as well. It could be something as subtle as submental swelling here that you may not initially think of as lymphedema, and the patient themselves may not even think of as lymphedema. It could be a little bit bigger in size, as shown here in this gentleman or here in this gentleman. It could be diffuse throughout the face. It could require trach placement, which goes back to the internal lymphedema that I just showed you, or it can even progress to that fibrotic stage that I mentioned as shown here. And Dr. Stubblefield, who is an expert in oncology rehab, has a really great presentation and infograph on the progression of lymphedema to fibrosis, and really teasing apart fibrosis related to RFS, or radiation fibrosis syndrome, and lymphedema. We don't have time to get into it this evening, but just know that fibrosis can be caused by RFS, but it is also related to lymphatic dysfunction. Okay, so wrapping up our initial lymphedema conversation, lymphedema is chronic and progressive. So we know that when the lymphatic system is impaired, it is going to need management from there on out. And if it does not have appropriate management, it will continue to get worse. It is progressive. And lymphedema can cause a variety of severe issues, including, as I mentioned, difficulty breathing, dysphagia, alterations in appearance, communication challenges, changes in voice, alterations in sensation, and difficulty with ADLs, such as driving in vocational tasks. I just had a patient a couple of months ago that was having such significant issues with lymphedema that he really can't move his head and neck normally anymore. So it's even impacting his ability to drive. He can't, turn to check the lane next to him. He actually has to turn his entire body left or right if he wants to look over either shoulder. Additionally, I've had patients that their vocation is significantly impacted. A few years ago, I had a physician on my caseload who had severe lymphedema internally and externally, and just with the way that the repair had been done in the mandibular region, it was difficult to move the fluid. So we would get it moved and improved in the session, but it would fill right back up pretty quickly afterwards. And she shared with me how that significantly impacted her job because she didn't want patients to see that something was wrong and that she had facial lymphedema. So at that time, she was wearing a mask at all times, patient facing, not because she was afraid of, like spreading germs or viruses or anything, but because she was just embarrassed about her appearance. So I know this conversation is about dysphagia, but there's so much that goes into caring for this patient population, and there's so much that they experience. I think it's important for us to be aware of the whole picture. So before we leave the slide, I do want to direct your attention just to the images so we can kind of talk through the different presentations, because lymphedema can look different across different patient populations and across different individuals. And as I mentioned, it is chronic and progressive. So you may have patients that had really severe swelling, like this patient here, but over time, as the lymphedema progresses, we start to see this sort of scarring down appearance. And I know some literature using fluoroscopy has said that over time the edema subsides, which is true. The edema starts to subside over time. However, when you view the upper airway with endoscopy, what you see is this scarring appearance. If I can find my mouse again, I can point it out to you. So this scarring-like appearance that is occurring throughout all of the structures. And at the bedside, what I tell my students to look for as changes in vocal quality. So oftentimes when patients have progressed more to that fibrotic stage internally, they sound like this because they have a lack of movement of the vocal folds. But what I have seen in my own practice is that with manual intervention and lymphatic care, we can improve vocal quality as well as anatomical, not only presentation, but function. And then bottom row of photos, again, just a variation in presentation of external lymphedema. It might be something as subtle as swelling in the submental and laryngeal regions. This gentleman here, I had just worked with him, so you can see the wrinkles because the fluid has been mobilized. This patient here in the next photo, if I can find my mouse again, has pitting edema as well as fibrosis. And then this patient had obviously severe external lymphedema all throughout the submental regions, ranging up into the face. So let's talk about the role of the SLP. A few years ago, I had another SLP ask me if it was really in my role to be talking about lymphedema and some of these other etiologies that cause swallow dysfunction for people with head and neck cancer. And that made me stop in my tracks and say, I mean, I thought that I was in my scope, but let me just do a deep dive and see what ASHA has to say. So when you pull up the scope of practice from ASHA, ASHA has the 8 domains, and there are numerous of them, as you can see, that would align with working with people with head and neck cancer. But for the sake of time, I want you to focus your attention on prevention and wellness. In terms of people with head and neck cancer, we know that there are many things we can do proactively to help our patients not only get through treatment of head and neck cancer, but get into that survivorship stage and thrive and live life on their terms again. And I think that if we are equipped with this knowledge and we are aware of the information to help better empower our patients, we can help them be more proactive. We can help prevent them from developing more severe issues such as end-stage lymphedema, and we can really promote wellness in their life, which I am very passionate about. So along those lines, when we talk about our role, we are speech language pathologists. So I went to Merriam-Webster to see what does Merriam-Webster define pathologist as. And according to the dictionary, a pathologist is a physician who interprets and diagnoses the changes caused by disease in tissues and bodily fluids. So obviously we are not physicians, but we are pathologists. So my opinion is that we as speech language pathologists should be identifying the underlying etiology or etiologies resulting in swallow dysfunction. And as we've discussed in depth so far this evening, people with head and neck cancer experience numerous issues that result in difficulty swallowing. So let's talk about how we identify and address the underlying etiology. First, I think it's critical that we spend time listening to our patients. If you've worked with someone with head and neck cancer, you're probably familiar with how tough these patients are. So many of my patients come in, they have a huge smile on their face, and they're just so grateful for any sort of treatment and intervention. But when you ask them, tell me about your swallowing, usually their response is, well, I'm doing pretty good, or I don't really have problems swallowing. But when you really sit down and take the time to talk with them, you often find out that they are sleeping in a recliner because they can't breathe at night. They're waking up multiple times a night because they're choking on their own saliva. They don't go out to eat anymore with family and friends because they're so embarrassed of their coughing and throat clearing. Maybe they've altered their diet. Maybe their marriage is suffering because they can't spend time with their wife anymore, going out to their favorite restaurant. All of these things I have heard from patients over the years, but it really takes us slowing down a little bit, sitting with our patients and hearing from them what they're experiencing. Additionally, as we've discussed this evening, there is a lot going on for this patient population, and it's critical that we're assessing the whole picture. We're thinking about the patient as a whole, although of course we want to help improve swallow function. It's critical that we're looking systemically and considering interplaying factors that may impact the patient on a larger scale. And of course, it's critical that we leverage multidisciplinary collaboration and care and really lean on our colleagues for their expertise and collaboration. And then, as is the premise of this webinar, it's important that we implement multiple modalities as needed. So my hope is that at the end of this webinar, you will feel equipped to do that. In addition to that, I think it's important that we build proactive protocols. And why would we do that? What is the ROI of building a proactive protocol? Well, there are numerous, including improving patient outcomes. As I mentioned, there are significant financial ramifications for this patient population. So by being proactive, we can be more aware of systems and processes and hopefully reduce financial burden. We can improve compliance and participation in cancer treatment and dysphagia treatment. We can increase the patient's support, comfort, and oral intake, reduce the risks of adverse health issues and medical costs. We can increase the rate of return to a regular diet and thin liquids following treatment for head and neck cancer. We can help avoid long-term use of feeding tubes, reduce hospitalizations related to pulmonary issues, diminish the risk for trach placement and subsequent trach management. We can also reduce the risk of voluntary total laryngectomy due to non-functional larynx post-treatment. We can decrease long-term need for outpatient therapy services, and we have the opportunity, in addition to dysphagia, to actually help improve voice and speech concerns. One quick note, I know it seems like so crazy that we can really do all of these things, but I've worked at several institutions throughout my career where at some of the institutions, we've worked to develop a proactive protocol, and others, we have just been in the initial stages. And unfortunately, even just recently, we had a patient on our caseload who was actually asking for a voluntary total laryngectomy because of non-functional larynx. And part of that was because of these chronic issues that he had been facing. And so that's where our team is really passionate about getting a proactive program in place at the system that I'm at now, because we want to avoid that. We know that we can better serve the patients in our community by getting involved earlier, giving these patients education about ways to manage their swallow function, their lymphedema, and the other ramifications that they are faced with. So how do we do it? Well, we know from the literature, if I can go back, that baseline imaging is absolutely crucial. Patients may have dysphagia prior to oncological treatment, and this may or may not be related to the cancer. The cancer itself could be causing dysphagia, or maybe they had dysphagia unrelated to the cancer that they weren't aware of, or maybe they were aware of. So it's important that we're getting that baseline imaging so that we can assess the risks and the benefit of oral intake during treatment. We need to remember that obviously swallowing is important, but eradicating cancer is the top priority for most patients, unless it's a palliative case. So we need to assess as a team the risk for adverse pulmonary issues due to dysphagia, as well as concerns for complications that could arise with reduced oral nutrition and hydration. For example, if I have a patient that maybe his dysphagia is mild at baseline, so I would like to keep him on an oral diet during treatment, but overall, when we consider his systemic health, maybe he has other comorbidities, maybe he's not very up and mobile, and he's already suffering from other diagnoses that will impact his fatigue and ability to push through cancer treatment, we might decide as a team that yes, we're going to try to keep him on an oral diet, but we're also going to talk with him about proactive PEG tube placement just to ensure that he does have the nutrients via PEG tube to continue to make it through treatment. So it's just really important that we're looking at each person individually and making recommendations that are specific for them. And then of course, discussing all of the information and the findings with the patient to determine the plan that best aligns with their goals. In my clinical opinion, both MBS and FEES are beneficial for people with head and neck cancer, and this is due to the overall risk of dysphagia, but also esophageal issues are common for this patient population and head and neck lymphedema. I say this with the caveat of understanding that challenges in imaging are common and the best test is the one that you have access to. So let's dive a little bit more into MBS or FEES. As I mentioned, I like both studies. However, I am cognizant, like I mentioned, of appointment fatigue and financial ramifications. So we'll talk about FEES first, MBS, and then I'll give you kind of my clinical rationale. I do like FEES a lot for people with head and neck cancer because we're getting that nice in color picture of the upper airway. We can look at vascularity, we can look at internal lymphedema, we can look with our certified lymphedema therapist to gauge how progressed the lymphedema is. We can look at secretion management, all of those things. And I like MBS because of the fact that we are able to look at the entire swallow continuum. So we're able to look at the oral, pharyngeal, and esophageal aspects of the swallow. And as I mentioned, esophageal issues are common for this patient population. Additionally, head and neck lymphedema is common. And with MBS, you can actually quantify the anatomy. So you can use measurements in systems such as the TIM software to measure the anatomy and then measure it over time, as I've done many, many times in my career. But if you were to use FEES, you could use the revised Patterson to rate the level of internal edema. So both studies I found to be highly beneficial in my own clinical practice. That being said, if you let's say you have both studies, but you're trying to reduce the amount of appointments that the patient has or the financial considerations, what I recommend is collaborating with your rad oncs or your ENTs on the endoscopy side of things. So if I've got a patient scheduled for a fluoro, I could collaborate with my radiation oncologist or the ENTs if either of those disciplines have an upcoming scope with the patient. And that way I'm still getting a nice in color picture of the lymphedema, secretions, etc. And then I can use my MBS to look across the continuum and also do the quantitative measures that I mentioned. But like I said, I like both studies. At one of the hospitals I previously worked at, we had it set up that patients could get both an MBS and a FEES done in one day. So it really just depends on where you're at and what the processes look like at your hospital. But I do want to default back on, if you're able to really consider appointment fatigue as well as financial concerns for the patient. Okay, so if we are talking about risk and benefit of oral intake for people with dysphagia, I have to mention the bolus framework. I'm sure you all are familiar with the bolus framework, but if you're not, I highly recommend looking into the publications by Dr. Phyllis Palmer and Aaron Padilla, but just kind of going through what bolus is and how you can use it. There are a variety of factors that we are assessing when we are thinking about the risk and benefit of oral intake for any patient with dysphagia, but in this presentation for people with head and neck cancer. So first and foremost, bolus variables. It's important that we're looking at if what the patient is aspirating, how much are they aspirating, and how frequently are they aspirating. Next, we want to look at oral care and oral health. So is there any evidence of poor oral infection control? Do they have a good oral care routine in place? What does their saliva look like? As we mentioned, many of these patients have xerostomia or alterations in saliva, such as the thick, ropey saliva that I mentioned. So what does the status of the oral cavity look like? The next factor is lifestyle and level of activity. So you want to look at mobility. Is the patient up and mobile? Are they frail, fatigued, or deconditioned? And are they dependent for feeding and oral hygiene? One of those that sticks out to me is the frail and deconditioning, because many of these patients end up having systemic fatigue throughout treatment. So they become more deconditioned compared to what they were prior to treatment. The next factor are unintended iatrogenic risks. So looking at your patient as a whole, do they have tubes? Do they have a feeding tube? Do they have a trach? Are they needing supplemental oxygen? What about their medications? How is that impacting their cognition and other systemic factors? Which leads to the last item, which is system status or general health. So looking at the patient's overall health, looking at their respiratory disease or GI complications, looking at their cognition and their immune status. So if you haven't seen this, like I said, I definitely highly recommend checking it out and printing it out and having it in your office, because it is an awesome reference. So let's talk about how we help our patients. We know from extensive research that we can improve swallowing outcomes with swallowing exercises as well as oral intake. So research conducted by Carter B. Mann in 2012 and Hutchison et al. In 2013 revealed that swallowing exercises during treatment for head and neck cancer have been shown to improve swallow function. Further research by Dr. Hutchison's team in 2013 and then a later publication by Heather Starmer have shown that those who eat and exercise have the highest likelihood of returning to a regular diet and decreasing time utilizing alternative sources of nutrition and hydration. So to sum up this slide, the best thing we can do for our patients is to encourage them to eat and drink during treatment and to conduct swallowing exercises as much as possible. Okay, so let's transition now a little bit, still in the exercise realm, but talking about exercise physiology. So if anyone else enjoys going to the gym, I like to think about developing care plans for people with dysphagia, similar to how a trainer would develop an exercise program for a client. The first principle that I want to discuss this evening is the principle of specificity. So for example, if you know me, you probably know that I used to powerlift and I was always trying to increase my deadlift. So if I wanted to increase my deadlift max, if I went and did leg raises, yes, that might potentially help my deadlift, but the thing that would help my deadlift the most would actually be deadlifting, which that is the principle of specificity, that training should be specific to what you want to achieve. So for people with dysphagia, we should have them swallow, because that is in alignment with the law of specificity. We should have them be doing the thing that has become impaired or deconditioned, which is actually swallow. Transference is what I just referred to about doing leg raises to improve a deadlift. Transference is the degree to which benefits gained from training in one area can be applied to other areas or activities. So the example for our patients would be swallowing versus non-swallowing tasks. So again, when we're thinking about our patients, they have so much going on in their personal life, appointment fatigue, financial concerns, they're going to treatment, every day. And maybe they're juggling full-time jobs like many of my patients are. How can we get the biggest bang for our buck? According to the principles of exercise physiology, the more specific we can be, the better. In addition to that, I think it's important that we understand as speech pathologists, because we are recommending exercise programs, some of these principles, including the principle of progressive overload. So I felt that Raymond and Lorenz said it better than I could, so I will read their quote. In order to continue making gains in an exercise program, stress to the system must be progressively overloaded as it becomes capable of producing greater force, power, or endurance. So what this means is, as speech language pathologists, we need to consider the intensity, the number of sets, the number of reps, and the frequency of completion for our patients. We need to progressively overload the system over time. So going back to my deadlift analogy, if you are trying to do a 1 rep max, you need to increase your weight every time so that you are overloading the system, right? So if my goal was to get to, at one point, a 300-pound deadlift, I needed to slowly increase the weight that I was doing. And this is in contrast to somebody that is trying to run fast. You might be wanting to do more repetitions of that versus, like a strength program. So when we are working with our patients with head and neck cancer, we need to think about that when we are looking at the impairments under fluoro or endoscopy and assessing what would be the best type of program for this patient. How can I be really specific for this patient, and how can I help them progressively overload the system? Okay. So my goal with this presentation is that you will leave with some tools in the toolbox, hopefully some that maybe are new to you or maybe are just a nice refresher. So as we just discussed, people with head and neck cancer highly benefit from oral intake during treatment for head and neck cancer if possible, and swallowing exercises. And as I mentioned, when we're recommending either thing, oral intake or swallowing exercises, I always like to frame the program from the lens of principles of exercise physiology, being as specific as possible, and looking at the sets and reps and frequency at which the patient is completing this exercise program that I'm recommending. Additionally, if you would like to follow like a structured program, the McNeil Dysphagia Therapy Program is a program that can help you with that and has research to support its use. So I am MDTP certified, and I do use it with some patients on my caseload from time to time. EMST is another tool that I use frequently in this patient population. There are many publications that demonstrate the benefit of expiratory muscle strength training to help improve swallow functions for people with head and neck cancer. And if you work with this patient population, you can probably attest that many people with head and neck cancer have chronic dysphagia and aspirate. And so if we are able to help improve their cough strength, we can help them improve their airway clearance. So I really like using the EMST 150 or 75 light in my own practice for that purpose. As we mentioned, oral care is absolutely critical to reducing the bacteria in the oral cavity. So encouraging patients to set up a routine oral care regimen is beneficial. And then I included honey on this page as well as a recommendation for oral mucositis. So there is some evidence in some publications that honey can be beneficial for oral mucositis, which again, as we saw at the beginning of this presentation, is very common in this patient population, especially during and just after treatment concludes, and can really hinder a patient's ability to eat and drink. So this could be a potential option for your patients. All right, so we talked a lot about lymphedema and fibrosis, which is great, but how do we treat it? Well, one of the gold standard tools to treat lymphedema is manual lymphatic drainage, or MLD. And a question I get a lot is, can you do MLD if you are not a certified lymphedema therapist? And the answer is yes, but you should take a head and neck lymphedema certification course. I took the Norton course, so I really enjoyed that course, but there are many options out there. If you have questions, feel free to email me and I can give you a list. But manual lymphatic drainage has been used extensively in oncology care for addressing lymphedema. So that graphic's just showing lymphatic movement. The next photo here, here we go. If I get my mouse here, is a picture of advanced pneumatic compression, or the FlexiTouch. So this is an at-home device that mimics manual lymphatic drainage. It has a chest garment and then a head garment, because the chest drains the lower vessels first and then moves up to the head and neck. So it's clearing that traffic jam and then moving up to the head and neck. And it's a 32-minute treatment. So this would be an adjunct to manual lymphatic drainage. And something interesting to note is that Jessica Greger at Mayo Clinic just did a publication on the use of FlexiTouch for improvement of internal lymphedema using quantitative measures in video fluoroscopy with TIMS, and found positive results in one session. So definitely something to check out if you haven't already. Next on my list are manual interventions. So this gets a little bit confusing, the difference between manual interventions and manual lymphatic drainage. Manual lymphatic drainage is a very light massage. If you've ever gotten a massage, it's not a deep pressure massage at all. It's very, very light. Manual intervention, on the other hand, can vary based on the clinician administering the manual techniques. So it can include stretching, intraoral, external techniques. Like in this photo I have here, the gentleman is doing a cervical manipulation, and the pressure can vary. It can be light or it can be more intense depending upon the practitioner. But in my own clinical practice, I always have the pressure be led by the patient. So the patient is instructing me how much or how little pressure they want. And I think that's super important to remember, especially, well, it's important for any patient population, but especially with people with head and neck cancer, because as I mentioned, they may have sensory changes throughout the just throughout this entire region. And so you want to make sure that you are in congruence with your patient in terms of what interventions you're doing, and having that open communication. Gua sha is just another tool that can be used to help with a variety of things: TMJ, fibrosis, etc. And we use gua sha tools in our clinic, and a lot of our patients do like having that external tool to help them just work on their fibrosis and lymphedema. In this bottom corner here, I've got an example of an intraoral technique. So I do intraoral techniques both for manual lymphatic drainage, but also for improvement of jaw range of motion. And some of the techniques that I use were provided to me by Walt Fritz, who's a mentor of mine, and that they help with jaw pain and improvement of jaw range of motion. This next picture here is again just demonstrating stretches and techniques for jaw range of motion and trismus. So you can have patients do a variety of stretches for the jaw. They can do jaw opening and closing. They can move their mandible left to right. Just different ways to keep the jaw range of motion intact proactively. The next photo I have here is a picture of a submental technique. So I spend a lot of time working in the submental region. As you saw in the photos that we presented so far, many of these patients have submental lymphedema and fibrosis. And when I scope patients while we are conducting manual techniques and working in the submental region, what I see is improvement in the base of tongue, in the follicular region, and in the epiglottis. And we have seen that in our clinical practice at the team that I work on, as we are scoping and doing manual techniques. And in the photo here on the right-hand side, you can actually see it. It's a small picture, so I apologize, but if you go to the Tim's Instagram or my Instagram, I have videos where I demonstrate this. If you're scoping live and recording externally at the same time, you can see how the techniques we are conducting externally have an internal impact on the anatomy. And just a quick story on this. I guess it was a year ago now, almost, or a year and a half, when I started at the clinic that I'm at now, we wanted to demonstrate to the radiation oncology team how manual techniques and manual lymphatic drainage were beneficial to people with head and neck cancer and head and neck lymphedema. So we had a patient come in who had external and internal lymphedema, and we brought in the radiation oncologist and some of the nurses and our OT colleagues, and they got to see firsthand how severe the patient's internal lymphedema was. So then we stopped the FEES. We did the 32-minute session with FlexiTouch, and then about 30 minutes of manual intervention. So me working with my hands. And then we had everyone come back in and we re-scoped, and it was just such a cool moment because everyone in the room went, wow. And it was just so cool because everyone saw that in that one session, the patient had that quick of internal improvement. Now, this isn't true for everybody necessarily, but you usually can get some level of improvement, whether internally or externally, when you start doing manual interventions with your patients. And it's just such a great feeling to know that you're helping to at least eliminate one of those long list of issues that they're dealing with. All right, I'll try to buzz through this so we can get to case studies. Okay, so additional tools, lingual stretches are great. I've worked extensively with PT and OT colleagues, and I had two PT CLT colleagues in my practice in Kansas City who used low-level laser therapy pretty extensively, specifically the Rhine device to help with fibrotic tissue, as well as deep oscillation therapy, so the device they use with the HIVA mat. As I mentioned, I love to use FEES with the patients to demonstrate biofeedback of how these techniques I'm recommending them to do, laryngeal techniques, submental techniques, can impact the internal anatomy. So this photo here, my colleague Kate and I are doing a FEES while I'm doing manual therapy and the patient's watching. I also use kinesio tape to help with lymphatic drainage, and they do teach those techniques at the Norton course, which is awesome. And then the last two photos here, I just have examples of different garments that patients with head and neck cancer may benefit from. So the Sigvaris does apply some light pressure, and then the Jovi pack on the end is a neck pad. You can also create chip packs, which again, they do teach that at the Norton course, and I believe the Chow course teaches that, as well as kinesio tape as well. So just things to think about, because again, we're thinking about financial considerations. Some of these devices that I'm mentioning are very expensive and they're not always covered by insurance. So sometimes we have to get creative and create custom items at our clinic, whether it's for financial reasons or because of the severity of or uniqueness of the lymphedema. And wrapping up almost our tools in the toolbox, additional things to consider are, as patients are put on feeding tubes, how are they specifically reacting to the supplement via feeding tube? Many patients that I've seen over the years have issues with some of the supplements on the market, and it can result in increased GI complications such as reflux, diarrhea, and even sometimes LPR. So when this happens, we've found good success with Kate's Farms, and we can work closely with the dietitian on this. Obviously, we're not dietitians, but that's where that interdisciplinary collaboration is crucial. We can bring up our concerns about some of these factors to the dietitian and help them document the need for switching to a product, Kate's Farms. It's a little bit usually more expensive than the other products on the market. So I've always had success in that collaboration with our dietitians and getting that approved. So just something to think about. Again, we know we have to assess the entire continuum, especially for these patients when we know that they often have esophageal issues. A bed wedge can be beneficial not only for reflux, but also for lymphatic movement at night. Many of these patients benefit from dilation or potentially Botox, which is where we need to collaborate with the interdisciplinary team to determine which is the best solution if we are thinking that there is UES dysfunction. And then hyperbaric oxygen chamber can be recommended if the patient has oral surgery. I've had several patients over the years that unfortunately develop osteoradionecrosis and need to go to hyperbaric oxygen chamber, but I've also had a few patients that have been able to go to the hyperbaric oxygen chamber to help with lymphedema. So additional options for dry mouth, which is common, consistent water intake, humidifier at night, papaya capsules may be beneficial for salivary stimulation. I know MD Anderson did some work looking at the benefits of acupuncture for salivary production, other products that could potentially help. A coral, which is lipid-based, xylomelts, which use xylitol, biotin spray, which use humectants and lubricants, or chewing sugar-free gum or candy. So again, when it comes to dry mouth, that is a huge beast, and really every patient's different. So just because xylomelts work for one patient don't mean that they will work for another. So sometimes it's just trial and error, and again, leaning back on that interdisciplinary team. So this is just a quick protocol example from Cleveland Clinic demonstrating how they built their protocol. And just in the sake of time, I'm going to zoom off to our case studies. But if you want an in-depth protocol with references, shoot me an email and I'd be happy to email you a protocol I developed that I would be willing to share. All right, so let's dive into case studies. So this first patient had squamous cell carcinoma. He was treated with radiation and chemotherapy. He had severe internal lymphedema that required a trach placement. Eventually, he was decannulated, but he still continued to have severe oropharyngeal and esophageal dysphagia. And eventually his lymphedema did progress to fibrosis. So he had a lot of complications. He went in for routine dilations. and he was PEG dependent for 1 year. After one of his dilations, he had some pretty severe complications and he ended up back in the ICU with increased difficulty swallowing. So at that point, I did a FEES and the team thought that he should potentially have his trach placed again. And the patient said, I've already been down that road. I really don't want to have it placed again. I want to try to manage my lymphedema internally and externally. Let's just go ahead and not do the trach. So he was educated on the risks and benefits of doing that. And this is several months later. So you can see a reduction in that full fibrotic appearance that we're seeing in the submental and laryngeal regions. So what were his results? His results were, as I mentioned, he was decannulated and then he had the dilation with complications, was discharged, and then saw me an outpatient, and we were able to get him off his PEG and return to a regular diet and thin liquids. And this was with manual therapy, manual lymphatic drainage, swallowing exercises, and progressive overload with food and liquids, and flexi touch. And the results were that on our last session that I saw him, we celebrated with the Boston cream pie, which was his favorite dessert. And I'm going to try to say this last part without crying, but this just gets me really emotional because I worked with this patient for a long time. And as you know, if you work in the outpatient setting, you develop relationships with these people. And on our last session, like I said, we celebrated with the Boston cream pie. It was so great. And I was supposed to see him the next week. And when I came into work the next week, I found out that he had passed away over the weekend. And the reason was because after his last hospital stay, he told me that he had filed for bankruptcy because of all the financial ramifications of the years of treatment and then subsequent complications. So he felt that he was burdening his family. And so he filed bankruptcy, and he said he was changing his medical status to DNR, DNI, and he would no longer be doing anything related to his medical management. And so over the weekend, he had an internal lymphatic flare-up and unfortunately passed away. And I share that because unfortunately this is the harsh reality that a lot of these patients faced. And I really want patients to feel empowered to understand the full picture of what's going on so they can make informed decisions. Even though this is a really sad story, this patient did know what was going on. He knew the risks and benefits, and he did have tools to manage the symptoms that he was dealing with and to do the best that he could to live life on his terms. So a little bit more of a positive case study. Our second case study, again, squamous cell carcinoma treated with radiation and chemotherapy. This patient had internal and external lymphedema, severe oropharyngeal and esophageal dysphagia. So this patient was not referred to speech pathology until after treatment for head and neck cancer. He actually felt like he was doing great, and then treatment ended, and he went in for a dilation and then had a flare-up of difficulty swallowing. So at that point, he was referred to speech, and we did a FEES, and as you can see in the top photo here, severe internal lymphedema. He had issues with both safety and efficiency, and at that point, we recommended speech pathology services, CLT with physical therapy, and the treatment modalities included kinesiotape, as you can see here, flexi touch, EMST, a compression garment, progressive overload, using both exercises and oral intake and manual lymphatic drainage, and various manual techniques that I was showing you earlier in the submental and laryngeal regions. So several months later, fast forward, he's super diligent about it, and I did his MBS, as you can see here in the bottom right-hand corner. So he did have an improvement in his digest score, but he still was having significant issues with efficiency. And as you can see from this blurry screenshot, he had a lot of residue, and that looks really concerning when you see that, but in comparison to the FEES, it was a huge win. So we kept going down the same track of all the things I just said, and several months later, he had another MBS, he did another dilation, and the results were that he was able to get off his PEG tube, have a variation of solids, so soft and bite-sized, some regular, and thin liquids, and he got to do what he wanted, which was tailgate at the Chiefs game. All right, and I know I'm so sorry, I'm right at 8 o'clock almost, but last case study, case study 3. So this patient had squamous cell carcinoma, again, treated with radiation and chemotherapy. He had minimal SLP intervention after head and neck treatment, and he did not feel that the treatment he received at that time was helpful, so he discontinued attending. 5 years later, so fast forward, he was seeing a chiropractor for severe neck pain and issues with completion of ADLs. He was seeing some benefits in his head and neck range of motion, but at his annual visit with his PCP, he mentioned issues with jaw and head and neck range of motion as well as secretion. So the PCP referred him to the SLP, which was me. And he told me that I didn't think it would be helpful at all, but since I trust him, I thought I'd give it another shot. So when I sat down with him and I'm like, hey, so tell me about your swallow function. He's like, I don't really have anything wrong with swallowing. I don't really know why I'm here. And then we kind of got into it. And like I said at the beginning of this presentation, really sitting down and asking your patients questions. Turns out he was choking every night. He was waking up multiple times a night, choking on his secretions. So not only that, he was having significant issues with secretion management, and he had made diet modifications because of his difficulty swallowing, in addition to the neck pain, which is what he cared about the most. So what were the results? He had an improvement in secretion management. He had an improved understanding of his head and neck, jaw, and swallow function related to lymphedema and fibrosis. He implemented a home program. He increased his variation in oral intake, and he reduced his occurrences of choking, which improved his sleep. All right, so just a couple of patient progress photos here, just demonstrating a couple of tools we talked about. Won't go in depth on the background, but this is a result of a patient with one 32-minute session with FlexiTouch. So you can see a significant reduction in the laryngeal region here for this patient with a total laryngectomy, as well as in the facial swelling. Again, in this patient, we're looking left to right here. We can see some of those wrinkles and a reduction in the fullness throughout this entire region, as well as some of those wrinkles here as the fluid is mobilized. Same thing, that was a FlexiTouch session. This is a three-month progress photo of a patient of mine where we use FlexiTouch, manual interventions, stretches, and MLD. And you can see visually the improvement in the appearance of the tissue, the reduction in pitting. We can actually see his jawline and an overall improvements in the tissue presentation. All right, and I know we are over time, so if anyone needs to jump off, you totally can, but I will stay on and answer questions for anyone that has questions. So with that, I'll go to the chat first. All right, let's see here. Okay. Okay, let's see. Is total laryngectomy ever recommended for a patient that had partial laryngectomy previously? I've had a patient that was several years post-partial who just wanted to eat, but after several stays, acute rehab stays, and therapy, her swallow was not improving. Every time she went home, she would continue to eat and end up rehospitalized for pneumonia. I had a hard time understanding why she wouldn't be a candidate. So Shelby, if you want to message and say if the physician said she wasn't a candidate, that would be interesting to me. I've never actually had that experience, but I know at the hospital system I'm at currently, our patients who were interested in elective TL, we definitely directed them to the appropriate facility, the appropriate otolaryngology department that would do that. And I have not heard of them having any pushback of doing that with any of my patients, but I'd be interested to hear from you if your physician said that she wasn't a candidate for some reason. And I do think it's important to note too, even if someone has laryngectomy, they still are at a high risk for lymphedema and fibrosis and still may have dysphagia. So it's important to set expectations and let them know that they're still going to need to manage lymphedema. And somebody said, is there a particular type of honey for oral mucositis? I've always heard anecdotally that Manuka honey is beneficial, but when I was looking at some of the publications, I did not see a specification. So I would say you should take a deep dive into the literature and check it out. But in some of the clinics I've worked at, the physicians would recommend Manuka honey. Okay, can you send the list of lymphatic drainage tools here? And Brittany, I will, this recording will be up on the website, so you can totally screenshot the list. And if, like I said, anyone wants the protocol that I mentioned that I have, it does have the list in there as well as references to back up the use of the tools. Okay, do you recommend any gold standard resources to guide our practice in determining the best dosage, frequency, intensity for dysphagia exercise programs? That is a really great question. I hope someone does a publication on that. To my knowledge, there's no like gold standard recommendation. How I even got interested in exercise phys for swallowing, or applying exercise phys to swallowing was because of my background with powerlifting, because I always had coaches that would, make a recommendation for my weekly training so I could get better. And at the time, at the place that I was working, we had like these I'm sure you've all seen them, the worksheets of here's the exercise, like do 10 sets or 10 reps. And I called my coach who had a background in exercise physiology and had the CSCS. I'm like, what do you think about this? Like, this doesn't make sense in my mind from an exercise standpoint. And then once I started like asking other colleagues and mentors, that's when I found that there wasn't necessarily any like hard and fast rules. But I think now there's much more awareness about applying the principles of exercise physiology to swallow function. But typically you're going to want to find what the person's max effort is, and then back off from there about 70 to 80% of their max. So I will say Dr. James Curtis has a really nice discussion about applying some of these principles, as well as determining like max effort on his website. So check out Dr. Curtis's website if you want to learn more about specifically this with exercise phys. And I know there's some other nice presentations about this topic that you should check out. If you just Google applying principles of exercise physiology to dysphagia, several of them will probably come up. How did you improve secretion management in case 3? I'm trying to remember which one case 3 was. Was that, of his choking on secretions, I think was that one. Let me go back to it real quick so I can recall. Okay. So with that patient, he was having issues with secretion, not saliva. Sorry, I'm thinking saliva. Issues with secretion management improved as his swallow function improved. So he did have fibrosis and lymphedema. So by mobilizing the lymphatic fluid, then we were able to better get the swallow structures to actually move how they are supposed to. And that helped with secretion management and his ability to actually clear those secretions. Oh, Penny, thank you so much for the positive feedback. Yes. Yeah, if you have questions, I see people are asking about the protocol. I'll put my email in the chat. And you can send me an email and I can email it. And let's see, sorry, I'm gonna go back up. Shannon, did you see any other emails or questions that were commonly asked?
There's also some questions in the Q&A, if you
Oh,
want to check
okay.
those too. Some
Okay.
questions about exercises, about like how much to recommend for reps, specific types of exercises.
Okay. I do see one that I get asked a lot, so I'm going to answer this one really quick. Would you do MLD in a patient with active cancer who are undergoing chemotherapy? No more radiation, last radiation course 2 years ago. I would talk with the medical oncologist about that, and it also depends on the type of patient. And by that, I mean, what are their goals? So whenever you're doing, anything, you want to assess risks and benefits. But if, like, let's say the person is more looking at palliative care, MLD and manual intervention can be extremely comforting. There's a lot of research that demonstrates that manual interventions really help improve quality of life. So if there were concerns about the patient having chemotherapy and getting manual therapy, but they were going palliative, then I would say the physicians would probably be less concerned. But I would definitely ask the medical oncologist. And just a quick note on manual interventions during treatment for head and neck cancer. Really, I think it's good to talk with your entire radiation oncology team when you're talking about implementing these things, especially during treatment for head and neck cancer. But if there is concern about spread of cancer or something like that, then you can also work below the level of the cancer. And that way you're not, in direct contact with the cancer itself. I see somebody asked about lymphedema courses, working with patients that are trached. So there's nothing specific there's no course specific that I know of that's specifically related to a patient with a trach with lymphedema, but the courses that I recommend are the Norton course and the Chow course. They both have specific courses for head and neck lymphedema for the speech pathologist. and they're great courses. And the course, Therapy Learning Company by Joy Hesse and Shelley Ryan is not lymphedema specific, but it is talks about manual intervention, specifically thinking about bolus pathway, like going from the oral to pharyngeal to esophageal aspect. So that's a good course. And then, as I mentioned, Walt Fritz has been a mentor of mine for many years, so I always recommend his courses as well. All right, let me pop over real quick to the Q&A. Okay, this is a great question. Sorry, you can tell that I like to nerd out on this topic. But Kelly asked, you may answer this question. If it's in the fibrotic stage, is there anything you can do to improve swallow function? This is a great question. Anecdotally, in my experience, yes. However, I say that with the caveat of we need to set expectations for the patient. So I'll give you a case example. I had a patient who was 10 years post-treatment, had radiation and chemo 10 years prior to me seeing him, came into the acute care setting, was having respiratory issues. We were consulted, we did a FEES. He was extremely fibrotic internally and externally. So at that time, I recommended intervention. I told him I could see him in the outpatient setting. We could get things, kicked off in the acute care setting. And he told me, you know what, I've already been down this road. I just want a feeding tube. I don't want to deal with this again. Let's just do a feeding tube. So he wanted the feeding tube. We put the feeding tube in, not me, but the doctors. And I gave him my card. I said, if you ever change your mind, give me a call. So he calls me 3 months later. It was super hot because it was summer. He's like, I just really want a drink of water. Can I come see you? So I started seeing him. And it was very intense. At first, we were seeing each other 3 to 5 times a week, and all the modalities I talked about this evening, the manual therapy, the manual lymphatic drainage, the flexi-touch, the gua sha, the exercises, swallowing exercises, progressive overload with oral intake. He did all of that. He was religious, and he went from severe fibrosis internally and externally with a feeding tube, only starting on water, to by Christmas time, he had his peg removed and he was on a regular diet and thin liquids with, some compensatory strategies. And his wife left the last FEES with him, and they were going on a date, which was so cool. And the last time I saw him, he had a party pack from Wendy's, which was great. But then it was about a year or so later, he called me and he was upset because he had regressed. And the reason he had regressed was because he could not keep up with how much he needed to do to maintain those results. So as lymphedema progresses, we have to think about that lymphatic load and how much damage occurred to the system, and really set those expectations with the patient. So in his case, although he did get better and he had some time where he was able to improve his variety of oral intake and his overall quality of life, he also had other factors, like I talked about, looking holistically. He had a special needs daughter that he cared for. So he had a lot of other things going on. He just could not keep up with all of the things he needed to do to manage the results. So yes, I have seen that you can help patients improve. And I always think back to that long list of issues. Even if we help solve one of the issues out of that long list of challenges that these patients face, it at least is something, a step in the right direction. That's my personal clinical opinion. I think hope is so important. I think it's important that we set expectations, but we don't know unless we try. Okay, let's see here. Okay, I answered that one. Let's see. What was the name of the course you mentioned that covered kinesiotaping? The Norton course covers kinesiotaping, and so does the Chow course, which Chow is CIAO, and that course is taught by Dr. Mallory Moore, who is a speech language pathologist and a CLT LANA, which is a very, very high honor to become a CLT LANA. What specific swallow exercise do you do to target task specificity? And an honest attendee, hit the nail on the head. The effortful swallow, that is my go-to, in my opinion, the best bang for your buck. When you dive into the literature and start looking through the swallowing exercises, and then you think about the like I said, the appointment fatigue and all of the things that these patients are going through, I just try to think, how can I maximize the time that they are spending to rehabilitate their swallow? So from an exercise, like swallowing exercise standpoint, I always, use the effortful as the main exercise that I utilize. So an attendee asked about the role of steroids and lymphedema flare-ups. I have seen physicians use steroids for lymphatic flare-ups, but that would, that's more of a patient-specific situation and dependent on the physician's practice, not something obviously that we would ever recommend. Okay. Anita said, sorry if I missed it, but did you mention anything regarding your thoughts on vital stem or other NMES and head and neck cancer? This is a great question. So, when you think about this patient population and you think about the mechanism of action for NMES, I'm not totally against it. I'm not against it at all. I think in terms of the modality of NMAS you're using, you should look at the device itself and look at the parameters and see if it's truly NMES. Is it truly giving you motor, or is it just giving you sensory? I think there's a huge misconception in our field about that, but if you talk to physical therapists, they can tell you more about that. However, I say that in the with the understanding that NMES is not going to work unless you've addressed the lymphedema and fibrosis first, because otherwise you are putting the electrodes on top of a lot of stagnant fluid. So my friends that work in the NMES realm will tell you that in their training that NMES will not be effective if you're trying to use it without addressing the lymphedema and fibrosis. But definitely would recommend that if you are thinking about NMES for any patient population, that you look at the various aspects of the devices on the market, the parameters, and what exactly they are trying to do with those devices. But like I mentioned, we've got so many tools that we're using. Usually NMES is one of like the last things that I use in my toolbox. Let's see. How often do you perform manual lymphatic drainage on a patient on a weekly basis? Great question. Depends on the patient. They need to be doing something multiple times a week, typically. It also depends on the staging. So I didn't get to really talk about this in the slides because as you can see, I had a lot of information that I did not think I would be able to cover, and I barely did it. But there's staging. So MD Anderson has a staging tool you can use for external lymphedema, and then internal lymphedema, we don't have an official staging tool yet, but I mentioned that we can use a revised Patterson to assess internal edema, which will be in the TIMS software soon. So I'm super pumped about that because I use that at like almost every time I do a FEES, especially if the person has head and neck cancer. Obviously, I'm using it then. So the amount of intervention is really going to depend on the severity of their lymphedema, but especially in those initial phases of intervention, I'm typically recommending that they're doing some sort of manual lymphatic work daily until we can see, how much their body can tolerate tapering off. So it really kind of depends. So I'm sorry that's not a super straightforward answer, Sarah. Okay. How do you approach oncologists about SLPs getting on board sooner? Okay, so this is a great question. And I mean, it just depends on the facility you're at, how I guess you would go about this. I usually try to meet with the radiation oncology team to do like a lunch and learn or an in-service or something, just let them know that we're there. So the first hospital system I was at that I did this at, I brought in Starbucks and I said I called them first. I called the nurse navigator and said, I really would like to intervene earlier with these patients. Could I come in and host some sort of lunch and learn? And she said, yes. I said, when's the best time to speak with the physicians and the nurses? And she said, the morning. So brought in coffee, bagels, all that stuff, and did just a short presentation and talked to them about what I wanted to do and why I wanted to do it, and presented the research, and then asked for their feedback. And they were extremely open to it. We set up a time to follow up because it's great if you get the initial meeting, but it's great if you get the initial meeting, but if you don't have a follow-up, then sometimes nothing happens. So I made sure that I set up follow-up. My follow-up was with the head and neck nurse navigator, and we decided that I would sit in on head and neck tumor board. So tumor board is a great place to get involved. You can see the cases that are going on within your facility. You get your face out in the interdisciplinary team so that they know you're there, and you can give your input right there during the tumor board. So that's how I did it. And then we had an automatic referral process where when the patients were diagnosed, they were automatically referred to speech pathology and CLT services, which I'm so sorry I zoomed past that in that photo protocol. But if you rewatch this webinar, there's a screenshot of the protocol from Cleveland Clinic that I had the opportunity to help develop, in which same thing, the patient's diagnosed, they're automatically referred to speech and CLT at the time of diagnosis. So my recommendation would be get in touch with the head and neck nurse navigator if they have one. Get in touch with the advanced nurse practitioners. Get in touch with your dietitian, just anybody on the team that is touching these patients, and let them know that you're there, what you're trying to do, and present the research. And usually they're pretty open to it. Like I mentioned, I've worked at several different places, and I moved about a year and a half ago, I suppose. And at the hospital that I'm at now, my colleague, my supervisor, she's amazing, and we've worked together to try to build a proactive protocol at this hospital. And we did the same exact thing. We got in front of all the radiation oncologists and the ENTs. We did a presentation. We showed case studies from our hospital where patients were not referred and the negative outcomes that they had because of a lack of prophylactic intervention. And at the end of the meeting, everyone's like, yeah, let's do it. Let's get it started. And since then, there have been many subsequent meetings with various people on the interdisciplinary team to keep things running smoothly. So I would say if you can get an order set, then that's going to be a game changer, because I always think about processes like if you leave, let's say you set up this program, but then you leave, is the whole thing going to fall apart? You don't want that to happen. So how do we get these things like set in stone so that if somebody on the team leaves, there's no break in the patient care? All right, so let's see. I'll answer one more question, and then we'll jump off just since it's 9:20 Eastern time. Let's see. Okay, so one of these questions was, my cancer patients tend to report a lot of mucus and feeling like when they swallow food, that the food gets stuck in thick mucus. Yeah, that is a super common symptom that a lot of patients have. And again, we could nerd out on saliva and mucus production another day, but saliva production is actually pretty complex. And unfortunately for these patients, in my experience, improvement of saliva production and subsequent mucus management can vary from patient to patient. For some patients, it hangs on a little bit longer. But in my experience, when we do help address the lymphatic system, and we're doing not only external techniques, but intraoral, so massaging the cheeks, massaging the tongue, massaging the floor of the mouth, and we're helping to re-stimulate the salivary glands. All of those things help, and they may notice that as you start to do manual lymphatic drainage and manual therapy in general, that they're having more like coughing with mucus, and that they can feel it. And that's actually a good thing, because they're starting to be able to clear that mucus out. It's not just sitting there hanging up. But to your point, when I do FEES with patients that have a lot of mucus, you can see the food just hanging up in the thick mucus. So we have to get that out. We have to get the mucus mobilized, which we can do that by increasing the hydration, by improving the lymphatic flow, and hopefully by improving the salivary production if possible. And unfortunately, there's nothing in the literature that says do this and your saliva will go back to normal. But I did provide a lot of different tools and techniques that are helpful for a variety of patients. So with that, we will go ahead and close out for this evening. But I just want to say thanks for everyone for hanging out for an extra 20 minutes. And if you have questions, feel free to send me an email. And if you are interested in those manual techniques, if you check out the Tim's Instagram or my Instagram on both programs, on both accounts, there's videos of me using Patient View and Tim's to demonstrate how the manual techniques impact internal structures. So with that, we will close out for the evening. Shannon, do you have anything else to add?
Yeah, just want to say thanks everybody for joining us. Hope you all have a great evening.
Awesome. Bye, everybody.